Hi and welcome back to another video of Medic Notes. This video is on hiatus hernia. A hernia is defined as the protrusion of a hole, or part of an organ, through the wall of the cavity that contains it into an abnormal position. So, a hiatus hernia is the protrusion of an organ from the abdominal cavity into the thorax. Through the esophageal hiatus. Hiatus hernia are extremely common. Around 1/3 of people over 50 years old have a hiatus hernia. There are two main types of hiatus hernia. 80% are sliding hiatus hernia, where the gastroesophageal junction, the abdominal part of the esophagus, and frequently the cardia of the stomach, move or slides upwards through the diaphragmatic hiatus into the thorax. The other type is the rolling or paraesophageal hernia, where the gastric fundus moves upwards and lie alongside a normally positioned gastroesophageal junction, creating a bubble appearance in the thorax. A mixed-type hiatus hernia can also occur, which has both a rolling and sliding component. The risk factors are old age, which is associated with loss of diaphragmatic tone, increasing intra-abdominal pressure due to chronic coughing, and increased size of diaphragmatic hiatus. Other risk factors are pregnancy, obesity, and ascites. For clinical features, majority are asymptomatic. Patients may experience gastroesophageal reflux symptoms, such as burning epigastric pain, which is made worse by lying flat. Other symptoms are vomiting and weight loss, bleeding, anemia secondary to esophageal ulceration, hiccups or palpitations if the hiatus hernia is big enough to irritate the diaphragm or pericardial sac, or even swallowing difficulties due to esophageal stricture formation. Sometimes the gastric outflow obstruction can happen, causing early satiety, vomiting, and nutritional failure. For investigations, esophagogastroduodenoscopy, OGDS, is the gold standard investigation. This picture of OGDS shows upward displacement of the gastroesophageal junction, also called the Z-line. It can also be diagnosed incidentally on CT or MRI scan. Contrast swallowing can also diagnose this condition. If there are symptoms of gastric outflow obstruction or weight loss, whereby an upper GI malignancy may be suspected, an urgent CT thorax and abdomen is mandatory. Conservative management. First-line pharmacological management for symptomatic hiatus hernia is a proton pump inhibitor, such as omeprazole, to reduce gastric acid secretion and aiding in symptom control. Lifestyle modifications such as weight loss, low-fat diet, taking earlier meals and in smaller portions, sleeping with head of bed raised, smoking cessation, and reduction in alcohol intake, as both nicotine and alcohol are thought to inhibit lower esophageal sphincter function, thereby worsening symptoms. Whereas surgical management is indicated when the patient remains symptomatic, despite maximal medical therapy. Increased risk of strangulation or volvulus, and nutritional failure. Any patients presenting with suspected cases of obstruction, strangulation, or stomach volvulus should have their stomach decompressed via a NG tube prior to surgical intervention. There are two types of surgery. Cruroplasty, where the hernia is reduced from the thorax into the abdomen, and the hiatus reapproximated to the appropriate size. Any large defects usually require mesh to strengthen the repair. Another surgery is fundoplication. The gastric fundus is wrapped around the lower esophagus and stitched in place. Aims to strengthen the lower esophageal sphincter, thus helping to prevent reflux and keep the gastroesophageal junction in place. Below the diaphragm, there are some possible complications of the surgery, such as recurrence of hernia, abdominal bloating, dysphagia, if the fundoplication is too tight or if the crural repair is too narrow. Fundal necrosis, if the blood supply via the left gastric artery and short gastric vessels has been disrupted. This is a surgical emergency, requiring major gastric resection. That's all for this video. Thank you.